So welcome to the Model for Improvement. I want to say that this is a very high-level review of this information, and ordinarily it's presented over several hours. And next year I get to go to Seattle and do an in-person workshop, which is always my favorite. So today, we hope, regardless of whether you're an expert, novice, or intermediate learner with quality improvement, that will kind of maybe provide some new strategies and skills to build your quality improvement acumen. And let's level set our understanding and language of improvement. So I've worked with hundreds of primary care practices and community health centers, and it's really important to make sure we're all kind of speaking the same language, because if you're an intermediate or an expert in quality improvement, you probably use PDSA like a verb, like, hey, let's PDSA that. And not everybody really knows, well, what does that mean? And we'll take a deep dive into the first three elements of the model for improvement. And then we'll talk a little bit about, along the way, how the model for improvement is essential for improving efficiency, quality, safety, and person-centeredness. One of the prime reasons for staff burnout is chaos in clinic or chaos in the workplace. And so having workflows and ensuring that we're measuring and making sure that things are done efficiently, that we have high quality, that we're not risking patient safety or even the safety of our staff, and making sure that services are person-centered. And by person-centered, I don't mean just patients. It also means our staff and all the others included in the processes. So sometimes with quality improvement, I feel like I'm the person kind of behind the, I've got the round wheel, and, I am working with clinics or I'm working with partners, and they're like, oh, I can't do QI. Like, I'm just too busy. And like Brene says, one of the most universal numbing strategies is what I call crazy busy. And I just encourage you to kind of balance the urgent and the important. So you're doing kind of urgent work and important work, delivering enhanced care management and community supports services. And here I am kind of asking, or we are asking you to like pause it. Let's just pause a second and assess how we're doing and see whether there are opportunities to improve or changes that we can try that are going to make things better. So we're going to go back to the basics. So this is a very basic 101 level course, as you may have noted or heard me say at our monthly meetings. And if you're going to become an expert in anything, you have to engage in purposeful practice. So having well-defined specific goals. So whether you're a violinist or you're a quality improvement newbie and you're just kind of learning how to do quality improvement, you have to have defined specific goals. Like the violinist maybe wants to play a particular piece of music. It has to be focused. Like, let's just have our QI group sit down, focus on quality improvement. And it involves feedback. So if you're a violinist, your master, your maestro will tell you whether you are flat or on, or you're going too fast, or you're going too slow, or you're sawing with your bow. And then it requires getting everyone out of their comfort zone. I would love it if today we could get people a little bit out of their comfort zone when it comes to quality improvement. We'll see whether we have time. So the model for improvement is basically 3 questions, and the model for improvement is ordinarily attributed to the Institute for Healthcare Improvement. It is actually outlined in great detail in the Improvement Guide, which is written by a bunch of statisticians. But you know how if you ever watch cooking shows and they say, oh, this is a deconstructed hamburger. If we deconstruct the model for improvement, it's really just common sense. So what a bunch of statisticians have done and published it in a book, and it's a great book. I have the electronic version, and I have like all kinds of highlighted sections. I know, no big surprise to you, right? it's basically, what is it that we're trying to do? What are we trying to accomplish? And it's common sense. I mean, if you're at home and you're trying to perfect how you do your sourdough bread, or you're trying to lose weight or make any other lifestyle changes, you know, the model for improvement almost always applies. Like, what is it that we're trying to accomplish? And attached to that are your aim. So what is your aim? And we're going to dive deeper into that in just a second. If you do make changes, how will you know that a change is an improvement? You measure. So with your sourdough recipe, you know, how perfect does it come out or not come out? How long does it take to rise? How long does it take from starting to finishing? This is very intuitive, but you still measure. If you're looking to lose weight or exercise, you know, maybe you get on the scale, or you know how many days out of the week you actually do that 1 hour of strength training or running on the treadmill. And then what change can we make that will result in improvement? Those are change ideas, sometimes called tests of change. So you come up with a bunch of change ideas and then you test all of them. And tying this back to the path work, DHCS and PCG, Pacific Consulting Group, our third-party administrator, has kept pushing us and saying, well, what are your tests of change? What are the PDSAs that you're running? And this is the piece that they are kind of on about, like, what change can we make that will result in an improvement? And they're very specifically talking about enrolling more people in ECM, delivering those services in ways that actually help people, connecting people with community supports, and enhancing those services. So ensuring that we're delivering food or medically tailored meals, that we're doing the whole housing side of things with housing navigation. So DHCS and PCG are really, really keen about tests of change. And for 2024, if we continue this work into 2024, they're doubling down on that. And they really are going to be saying, like, what tests of change are you going to be making? And then when you do those tests of change, you test them on a small scale, and that's what the PDSA is. And we'll be talking about that tomorrow. So Maria, Berenice, I'm going to pause and just ask if you can let me know if there's anything in chat. Are there any? Actually, I can access chat, which is very nice. I'm going to take a second to scroll through chat. Adriana, thank you. Front Street, glad to see you here. And you have seen that movie. Oh, awesome. So you might maybe even remember that scene of Johnny Five going, input. QI, a new realm. So Juliana, I will say that over the past 2 weeks, I have met twice with an Alliance QI advisor that is providing assistance to, I believe it's Emline Clinic. It might be both of the county clinics. And we were talking QI talk and applying all of these same principles exactly to Santa Cruz County clinics, although it was around cervical cancer screening, so something a little bit different. Dan, hopefully we'll have something that you can use. Jen, so glad you're on. Learning best practices for QI tools applicable to this space. So Emily from SCCH also said, is this going to, she sent me an email this morning. She said, is this going to be like just basic QI stuff, or is it going to be specific to ECM and community support? So maybe we'll have a little bit for everyone. All right. And Maria, did we have any responses to our Zoom poll?
Yes, Trudy, let me pull up the results. So out of 10 people who replied to the poll, we had 5 who are intermediate and 5 who are novice.
Ooh, thank you. Great. Thank you for responding to the poll. Okay, so no experts. I imagine we probably do have experts, but you're just being a little bit modest. But let's continue. So if you like, there's I think it's a Hawaiian word, lanyap. So it's a small gift. So, I told you that I kind of started on this journey very, very early. And we had a nonprofit organization that worked with our clinic. Based on a grant that I wrote, we were part of the Safety Net Medical Home Initiative, which was a national kind of demonstration project for practice transformation. And I'll tell you what, I could not remember those 3 questions for the model for improvement if my life depended on it. I'm like, what are those questions again? I just do not remember them. And even when I did remember them, I actually thought they should be in a different order. But anyway, that's a tale for another day. And I could never remember what Plan, Do, Study, Act stands for. And when we were doing one of our learning sessions, I asked one of the folks that we met with, are you doing PDSAs? She's like, PDSAs. And so I just started to explain it to her. And she's like, oh, yeah, I know what those are. But I could not keep track of what was what, and like, what do you do in the plan part, and then the do part, and then what's the study part? Like, how does that even relate? So very early on, I created this laminated sheet. So it has the model for improvement on one side, the Plan, Do, Study, Act on the other side. And if you would like, we can send you a laminated sheet, or up to 5 of these. We're happy to get them printed off, put them in the mail, and send them to you. You just have to let Maria know where we should send those to, and we can send them out to you. We're also very, very happy if you want to make your own. And we can also, and we're happy to provide the PDF of this. And all you have to do is just kind of trade out the logo. It's pretty easy peasy. I can't see myself on the Zoom. Okay, so here. All right, so I'm not doing a very good job with I think it's because I have that's hilarious. Okay, I can do it like this. So here's kind of what it looks like. It looks like this on one side, and it looks like this on the other side. But it's the size that you can put in a white lab coat. So if there's one thing that you take away from today, it is that every system, whether you're doing ECM, community supports, or like any system, even your system for getting that perfect sourdough loaf, every system is perfectly designed to achieve exactly the results it gets. This saying is attributed to Don Berwick a lot. He was the president and CEO of the Institute for Healthcare Improvement for many years. And if you take a QI course from IHI, you will definitely bump into Don Berwick, either his name, or he'll be teaching part of the course. Every system is perfectly designed to achieve exactly the results it gets. If you don't like the results, then you need to redesign the system. So that first question, what are we trying to accomplish? I love Don Berwick's quotes. Some is not a number, and soon is not a time. And I always add on to that, and hope is not a plan. So what is it that we're trying to accomplish? And I was working with a practice in Boston, and the medical assistant was doing a really great job of doing pre-visit planning to identify, I think, who was due for mammogram. And I asked her, well, how do you know that you're making a difference when you're doing this? And she kind of shrugged her shoulders and said, I hope I am. And then we started looking at the data. We compared her team to another team, and it was clear that she actually was making a difference. But some is not a number, soon is not a time. So if you're going to be doing quality improvement, set an aim now, and don't get stuck, and make sure your aim has heart. Be ambitious and bold. And I will say that the California Office of the Surgeon General has set a bold and an ambitious goal of, you may or may not have heard this one, but reducing adverse childhood experiences and toxic stress in half by one generation. That is that is a bold and audacious aim. And then draft as SMART aims. So as a clinician, when I would see patients and they would say they wanted to make a change, like take their medications as directed or lose weight or whatever, I would say, let's put that in a SMART aim. I do this to my children as well, like right around New Year's Eve and New Year's Day, they'll send me their New Year's resolutions and they're like, hey mom, guess what? I'm going to do XYZ. And I'll text back, that's great, honey. Can you please put that in a SMART aim? And I will also quote Yogi Berra, if you don't know where you're going, you'll wind up someplace else. And so having a SMART aim really sets like, where is it that you're going to go? Maybe we need another laminated sheet for SMART aims, but it took me a while to be able to kind of rattle these off myself. But over the years, I've developed these tips for setting aims. So don't say, we're going to increase whatever it is by 25% or 71%. Like, I don't know what that means. There's no point of reference. Like, we're going from what to what? I have no idea. Increasing from 20% to 30% is the same as saying we're going to increase it by 50%. And I don't want you to kind of your eyes to glaze over now, but a wee bit of math. So 50% of 20% is 10. So if you add 10 to 20, that's 30%. So if you're going to increase medication adherence from 20% to 30%, you could say we're going to increase it by 50%. But 50% can mean different things. So it can mean you're increasing it actually by 50%, or it could mean something like we're going to increase from 20% to 70%. And people say that's increasing by 50%. It's actually technically increasing by 50 percentage points, but people say that's what they mean when they say we're going to increase by 50%. And that's the difference between relative and absolute change. Relative change always sounds more impressive. And so on the news, whenever they're trying to make something dramatic, they'll talk about relative change. So, you know, gas prices are going up 33% when actually they're going up $1. They're going from $3 to $4. But when you write your SMART aims, you always want it to be in absolute terms, because otherwise there's no reference point from where to where. So basically, don't make people do the math. Be clear. And being clear sometimes means including the numbers. So for example, when I was talking to Naomi from the Alliance, who's just absolutely brilliant and an amazing quality improvement advisor from the Alliance, I've worked with her since as long ago as 2016. She said, well, here's what our SMART aim is for improving cervical cancer screening or PAPS. And I said, okay, so what's the number? So if you want to go from 35% to 60%, how many additional kind of cervical cancer screenings do you need to do? And she broke it down for, I think it was M-Line Clinic. I can't remember if it was M-Line or Watsonville Health Center, but she looked and she kind of broke it down by the week, and she said, okay, well, we're doing 4 per week. And if we want to get to our SMART aim, like where we have set our aim, we need to do an additional 20 PAPs per week. What is it going to take to do that? And, you know, that's kind of really digging into the numbers and doing a pressure test. Is this reasonable, or are we just like way too lofty? So, and I'm sure all of you on the call will come up with better sample aim statements, but for an example, when we were meeting with the ECM work group, and then when we did our listening sessions, there was this discussion about increasing medication adherence. So secondary medication adherence is whether patients are taking their medications as directed. And so one sample aim statement would be by December 31st, we will increase secondary medication adherence from 50% to 80%, because that can really have a profound impact on control of, say, diabetes or hypertension or kidney disease. A community supports example would be by December 31st, we will improve, and this is awkwardly worded, so I'm sure you can do much better, but by December 31st, 2023, we will improve from 25% to 35% of our individuals demonstrating at least a 5-point improvement in their A1Cs. So at least one of our food/medically tailored meals providers tracks their individuals who have diabetes, their A1C values. And, you know, the hope is that, wait, hope is not a plan, right? But the hope is that if we're providing nutritious meals that are geared towards a person with diabetes, we will lower their A1C. And then, you know, from the housing perspective, we know that several of the navigation service related community supports are looking at member satisfaction. So by December 31st, we will improve the percent satisfied or very satisfied with their housing navigation services. So, you know, again, the test, are those SMART goals? Are they specific? Yes. From one thing to the other. Is it measurable? Sure, we can measure it. One of our food providers is asking patients what their A1Cs are, and there's another food/medically tailored meal provider that actually goes through SCIO to get the patient A1Cs. So, you know, either way, there's a way to measure it. And then, you know, of course, by administering a satisfaction survey, you can collect the data for that. So remember when I said that we were going to try to get you out of your comfort margin? What I would love to do is have you write an aim statement in chat. So I'll do it too. Usually this takes folks about 3 minutes. And if you want to do it specific to your, to the work that you do, either community support or enhanced care management, or if you are, I think RPM, CCM on our call is Doug, if I remember correctly. If you want to do it with regard to RPM or CCM or whatever, put your SMART aim in chat. If you can't come up with something that is work related, you can do something in your, you know, personal life, whether it's related to exercise or something like that. I'm recovering from a fracture, and so I have to do strength training, and I just am not pleased with it. So I will put into chat my SMART aim around my recovery for my fractured bone. But you go ahead. I'm going to give you 3 minutes on the clock. Ready, set, go. All right, 10 seconds left. Jen, increase the number of new referring provider case managers by 50% over the next 12 months. That's great. All right. So Jen, I know if you had the numbers in front of you, just like Dan, to be specific, what we would say is, so if I were to kind of rephrase that, as your QI guru, I would say by, okay, so it's 12 months. So I would say by October 2nd, 2024, we will increase the number of new referring providers / case managers from, and then you would need to know your baseline, and then what 50% of that baseline is to this other percentage over the next 12 months. Me, I'm by October, the end of the month, I will improve finishing all exercises in my training routine from 80% to 95%. And I have actually started measuring that. I have a notepad in my iPhone. And so every day I write whether I did all of them or not. So that's my way of measuring. Maliha aim as an intern is to work on projects that assist people and families in finding safe and affordable homes, especially those who are low income. For example, conducting research, advocating for policies to support affordable housing, or supporting initiatives to link people with housing resources. That is a great aim. If I were your QI guru or coach, I would find a way for you to actually measure that. So you can say, well, here's where I'm starting. And here's how many projects that I'm working on that assist people. And here's where I want to be by the end of my internship. Tangung 01, there will be 100% compliance rate from 70% current state for care manager use of the SMART format when writing their care plans. Love that. If I were to kind of critique that a little bit, I would say by when? So how much time is that going to be by December 31st? Doug, engage all new members, measure the acceptance to co-managed care, achieve acceptance of these new benefits, set relevant criteria, timeline allows quarterly standards. Those all sound very, very interesting. I wonder if you could choose one of those and build a SMART aim. Juliana, increase frequency of project reporting from once to twice a month. And Juliana, do you have a by when? Like how much? By when? It sounds like you have a baseline of once and you're going to shoot for twice a month. Be able to increase the number of home deliveries we are making from 50 to 100 in the next 6 months. That is great, Vanessa. So I would say so the date by when, because, tomorrow or the next week, that next 6 months might change a little. Help patients and families close the gap between nutrition recommendations / referrals and daily habits by 40% in the next 6 months. That is great. So Roxanne, my advice would be to know, and I know that you're kind of surprised by, oh gosh, she's going to ask us to do what? But as long as you need to know what your baseline is so that if we're going to increase by 40%, we're going to go from this many to this other number. And then in the next 6 months, make sure you have a by when date. All right, nice work, you all. So for the model for improvement, there are kind of 4 components, and we've talked about the first. And so we'll go to the next, which is how will we know that it changes in improvement, but we're only going to touch on it very briefly because we're going to be digging more into data tomorrow. So how will we know that it changes in improvement? You have to measure, and there are different types of measures. So there are outcome measures, process measures, balancing measures, and there's qualitative and quantitative data. So we'll dive into that a little bit tomorrow. So stay tuned. And I just want to say that when it comes to measurement, when we're talking about quality improvement, it's important to remember that it's data for learning, not accountability or judgment, which can sometimes be difficult if you are in an accountable care organization or ACO. That measurement is actually about accountability. And if you were at the monthly meeting, the PATH monthly meeting, we talked about I mentioned the care-based initiative. So the primary care practices that have a managed care plan, or whether they have Medicaid or Medicare or even another type of insurance carrier, they have to demonstrate that they are providing quality care. So there are certain very standard measures in healthcare service delivery, whether you're a hospital, to ensure that patient quality and safety are not at risk, and that people are providing high quality care. For the Alliance, those are called the care-based initiatives, and there are financial implications for reaching or not reaching those goals. So also noting that all improvement is change, but not all change is improvement. And if you're going to make changes, you want to know whether they result in improvement or not, because sometimes they don't, and sometimes it matters, and sometimes it doesn't. So I'm putting kind of a little bit of a grayed out check mark around how will we know that a change is an improvement. The answer is we measure, and we'll talk about measurement and data tomorrow. So let's move on to change ideas. So what changes can we make that will result in an improvement? Those are those tests of change. So DHCS is specifically using tests of change, but you come up with change ideas first. So how do you discover opportunities to improve? I think we all intuitively do this. I think it is very, very human to kind of critically appraise and think about like how things could be improved. I mean, even if you go out to eat when your server is inefficient or the processes are inefficient, or you're sitting there waiting for your bill for your meal, you think, wow, do they have some opportunities to improve? So it's, you know, by observation, it's just keenly what we do as humans, honestly. Process maps are a great way for identifying opportunities to improve. When I do process mapping with practices and we map the current state, and as we're going along, they're just like, oh my gosh, why are we not changing this? Why are we not changing that? And I have to tell them, like, slow your roll. Let's just get the current process map down, and then we'll brainstorm and figure out what are some opportunities to improve. There are root cause analyses. So what in the world is, so the one that I think about a lot and that our team talked to PCG about was how can, especially for the food and medically tailored meals, like how can they, because there seems to be a fair bit of saturation for that community support. And so I don't know whether there's competition, but, you know, people have capacity at this time. And so how do we get community supports and specifically food, medically tailored meals to other people? Like, what are the root cause analyses for not, you know, not getting more people to take advantage of community supports? And we'll touch on that in a second. Publications, change packages that say, here's how you do XYZ, here's what other people have done. And so you kind of steal shamelessly really good ideas. Online literature searches. So I was just doing a search the other day around something related to telehealth experts. So, you know, a coach or a consultant or other experts in the field, people at other clinics or other people doing community supports or ECM, you know, hear from them, especially their lessons learned, market and other drivers of cost of care, change concepts. So there are the 8 change concepts of practice transformation. There are the 10 building blocks of high performing primary care practices. Other organizations, that is some of the best learning, and frontline staff, they are truly the experts of the work. And they are, if you listen to them and you give them easy avenues, they'll give you feedback on what to improve. I think we often forget that, you know, at the heart of what we're doing are patients and families. And in our listening sessions, we heard some really good examples of asking patients and families on how they can improve. So even having the delivery person who's delivering the food or the medically tailored meals, asking the patients and families, you know, how is this working for you? And, you know, they would get feedback. Well, you know, what you're providing me doesn't fit in my little tiny refrigerator. Like, I have a little kind of dorm refrigerator, and the things that you're providing me don't fit in there. Certain initiatives or collaboratives, data assessment. So so somebody coming in and doing an assessment, either an online assessment or questionnaire, brainstorming, the 5 whys, shadowing or observation. So I often go to clinics and I shadow, and I can pick up on kind of ideas for improvement. Fishbone diagram, driver diagrams, I do use. Pareto charts, I don't use. Hunches, is really all about, I wonder if we were to change XYZ, if that would work. I mean, that happens all the time. And then surveys, yes, but mailed surveys, inserts some selection bias, of course. So the 5 whys kind of goes like this. I'll give you a really quick example, and that is this is a real 5 why. And maybe you've heard this one before, but the Washington Monument was degrading. So the stone was degrading, and they asked, well, why is the stone degrading? And the stone was degrading because of all of the bird poop, and it was acidic, and it was degrading the stone. Well, why was there so much bird poop? And the reason was because there are so many delicious and tasty spiders. Well, why are there so many delicious spiders? Well, because there are all these gnats that the spiders like to eat. And why are there so many gnats? Well, it's because we turn the lights on to illuminate the Washington Monument at dusk, and that's when the gnats are out. So they really dug into the whys, and all they did was delayed turning on the lights until later in the evening, and then there were no more gnats, no more spiders, no more birds, no more bird poop, and so they were able to kind of get at the root cause of why the Washington Monument was degrading. And if you've ever been around a 4-year-old, you have been pimped on the 5 whys, even more whys. But why, Grandma? But why, Grandma? But why? All right, so moving on. So tests of change. So, a few things just off the fly, just kind of thinking here for enhanced care management. So if you want to decrease secondary medication non-adherence, and that's that the patient is not taking the medication as prescribed, there are a variety of things you can try. Provide patients with med boxes, call or text to remind them, help them download a phone app that reminds them, help them set phone alarms, tie taking medications with something else that they do, like brushing teeth. So if there's a medication you need to take at bedtime, put it next to your toothbrush. Get the prescriber to simplify the prescription. So combine pills, like combined hydrochlorothiazide, ACE inhibitor pill, or have fewer doses per day. Choose a different medication that doesn't require a patient taking a medication 4 times a day. And they're just like, I could keep going on different slides. There are so many strategies, but, any of those are changes to try, or if we use the DHCS terminology, potential tests of change. We'll talk about this a little bit tomorrow, but if you're going to try something, you're going to test something, you don't want to test a bunch of things all at once. So if you were to implement all 6 of these and there was an improvement, you would have no idea which one it was. Like, was it because we loaded their med boxes, or was it because we got the prescriber to simplify the prescription? So if you're going to do tests of change and you want to know which one is resulting in improvement, you usually only want to do 1 or maybe 2 and test on a small scale, but we'll talk a little bit more about that tomorrow. So for community supports, for tests of change, using that terminology, during our listening sessions, there are several things that kind of bubbled up. And one was a community support food provider that recognized that the Santa Cruz County is a little saturated with food providers. And they said, well, what services are missing? Like maybe that is the space that we move into where, others are providing groceries, others are providing boxed meals. Maybe there's another way that we can kind of expand the services in Santa Cruz County, ensure that food packaging matches the patient storage options. So this came up twice, actually. So one was that the food packaging didn't fit into small refrigerators. And the other one was that for patients with hypertension who should be on a low sodium diet, they were providing soups. And for people who really love salt like I do, if you give me a soup that is low in sodium, I'll be like, maybe I'll skip it. So kind of making sure that food and food packaging matches patient storage options and preferences. The other thing that we talked about with ECM and community supports providers was they often get the referral when it's a little bit late after a patient has been discharged from the hospital. So is there a possibility to join the quarterly discharge planner meetings, for example, to make sure that nobody kind of falls through the cracks going from a hospital admission to home and, is without food or with care management. Taking it to the street was another one that we heard. So literally taking it to the street. So there are patients who are not seen in clinics. And so they're kind of unseen and unheard. So, do we go to the homeless shelter? Do we go to the sobering center once we get it up and running? Do we literally take it to the street to make sure that people who qualify for enhanced care management and community supports are receiving them? Because I feel like we're missing a big population. Another one that we talked about was this concept of academic detailing. So if you want clinics to refer for community supports, whether it's for food or housing, can you get in on a provider meeting and talk about your services and how to hit the easy button on referring patients for community supports? And what one person pointed out was, so maybe it's the providers are not the ones who actually do the referrals. They tell their medical assistants or LVNs/nurses make the referral. So, is it clinicians or support staff that you kind of get in on a meeting? Go on site to ECM providers because they don't know what you provide and how it's different from another housing navigation service or food provider. Provide a direct line of communication in case of emergency. So one of the food providers said, that it was really, it was huge that a person was able to call them and say, hey, I didn't get my food. I don't know what happened, but I'm like hungry. And so they were able to fix that. Having simple referral forms that are either online, so you can give somebody a link or you can print it to really, really, really hit the easy button on referring, creating one-page flyers. What else? Like what other tests have changed can you think of? And feel free to put it in chat if you have any superb ideas. But these are the things that have kind of bubbled up for tests of change during our listening sessions. And when we met with PCG, we're like, oh my gosh, these listening sessions are amazing. We're learning so much, like all these things that people can or should be doing. And our coach kind of said, well, how are you going to share that? And I'm like, okay, right, I get it. So we'll try to get the word out. Here's an example of a fishbone diagram that I honestly have to say, I don't use it too much, but I get asked all the time for a template. Here's a project charter. We don't have time to do this in real time, but this is often when I get out of my comfort zone. So we do a project charter together in real time. But if you want to do a project charter, just let us know. We'll meet with you and we'll kind of walk through the steps of a project charter. And we have this form that we can send out if you're interested in it. So once you get your project charter done, you want to make sure you have a SMART aim, what your measures are going to be, what your change ideas or tests of change might be, and what are the PDSAs that you can run. So that is it for today. A lot we know. And, we're really just kind of touching the surface. We really look forward to continuing this journey with you tomorrow. We will provide the slides. We will provide the recording and the resources that we mentioned, but same place, same time tomorrow. And before we finish up, I just want to say that we did not pause much for comments or questions. So let us know at this time if you have any comments or questions. And I want to give a shout out to Dan Chavez. So Len Yap is, so according to Dan, who was nice to chat me privately to correct me, he said it's pronounced as a French word. Len Yap is a Cajun French inspired noun that means a little extra, often used to describe something good. Thank you so much, Dan, and thank you for being kind. All right. Well, let us wrap this up then. Let you get on with your afternoons. Hope to see you tomorrow. Let's stop our recording.